Hello and welcome to my presentation exploring how health and educational services can collaborate to improve support and outcomes of adolescents with health-related needs in secondary schools. The context of my research is currently there are 1 in 5 adolescents in the UK living with a long-term health condition. This is one estimate. There are several estimates, and they are mostly around 25 to 30%, which means that every single school in this country will have plenty of adolescents with long-term health needs attending school. Research shows that schools fail to support these students, students with long-term health conditions, including disabilities. We know about the bidirectional relationship between health and education, whereby education is an important social determinant of health, while physical and mental health during adolescence is key for education and vocational outcomes. There are various risk factors identified by previous research that concern poor health during adolescence. Some of these are psychosocial risks, absenteeism, reduced educational outcomes, and increased likelihood to end up not in education, employment, or training after the age of 18. Some of the barriers identified by previous literature include schools using the medical model versus the socio-ecological model, meaning that schools focus on supporting physical needs but don't really go beyond that. There's a lack of empowerment within this population. They tend to keep their heads low and not ask for much, and that also includes their parents. There's plenty of legislation protecting the rights of these adolescents, such as the Equality Act or the statutory guidance to support pupils with medical needs in schools, but there is absolutely no monitoring on school level, local authority level, or national level. There is also a lack of coordination between health and education, with both services being unsure how much information they can share, whom they can share it with, and generally making support not really transparent. This research was published a couple of weeks ago after I completed my research and submitted my thesis. Michael Marmot is a key author for my literature review. He has explored the social determinants of health. Education is a very important one, and he talks about the bidirectional relationship between health and education. He found that the pandemic increased the levels of social, environmental, and economic inequality in society, and thereby also damaging health inequity or increasing health inequity. Some of his recommendations include a better commitment to engage and communicate with young people, an early response to improve mental and physical health among children 0 to 5, to address social determinants of health, and to improve educational attainment. My research question was, how can health and education services work together to improve processes around adolescents with chronic, life-threatening and life-shortening health-related conditions? I had 5 subsidiary research questions. They concerned policies, guidance and legislation, transition and integration, the awareness of educators, interaction of different agencies, and social, emotional, and mental health needs of these pupils. I used a mixed method research where a quantitative survey, the findings of a quantitative survey served as the base for qualitative exploration using semi-structured interviews. I used reflexive thematic analysis to generate themes of the semi-structured interviews. This is a further developed version of the original Brown and Clark paper that highlights the active and reflexive role of the researcher in generating themes rather than identifying emerging themes. There I had 3 participant groups: school nurses, pupils with long-term health conditions in secondary schools and their parents, as well as education professionals. This diagram shows some of my key findings. As you see, communication was absolute key mentioned by pretty much all participants, and mostly it concerned the lack of communication between different agencies within schools where information didn't trickle down from say, absence officers or senior leadership to individual teachers. Lack of communication between schools and parents, between schools and hospital schools in terms of in case of long-term absences, etc. Some further themes include invisible needs connected with physical needs. These would be learning needs and social, emotional, mental health needs. There's very little support from them, and also there is very little awareness around them. The importance of health representation in school nurses, that was mentioned by many participants, empowerment of this population, or lack of empowerment rather, to participate, to ask for anything, and the barriers faced by schools where there are very high expectations on them to meet the needs of various populations, but funding for this particular population hasn't been looked at or increased for years. So some more details about my findings. It seemed clear that schools do not always know what parents know, and healthcare providers don't always know what schools know. And I guess this is a result of the lack of communication between the different parties and different agencies involved. Lack of participation, that's these students often just keep their head low, don't ask for much, don't participate in support planning procedures, risk assessments, and it's the same with their parents who are often not invited to relevant meetings. Same with healthcare providers. There's a lack of alignment of goals between schools and healthcare support healthcare professionals, where often schools see this as an addition, see meeting health needs as an additional burden of teachers, rather than considering good health as an outcome of a good quality education. It's considered to be a zero-sum game on both sides. So either we educate or we meet health needs. We can't do both. There's a lack of awareness around invisible needs, such as mental health needs and learning needs. And there's a lack of transparency of support systems within schools, where parents don't know where to go, pupils don't know where to go, and healthcare professionals also don't know whom to contact within schools. Some of my implications here, risk and protective factors were discussed by all of my participant groups. Environment can be a protective factor if it includes, say, support for physical needs, teachers with a good awareness of medical needs, health-related needs, a supportive attitude of senior leadership towards the outcomes of these students and the support of these students. And if all this is missing, then environment can soon become a risk factor. A strong relationship with a trusted adult in school is a good protective factor. Absenteeism is a strong risk factor in this population. Communication, collaboration, when it works, it's a protective factor, and when it doesn't, then it becomes a risk factor. Individual factors such as the ability to advocate for themselves, the knowledge of one's own needs and rights, self-confidence, these are protective factors. And if pupils lack them, then they become risk factors. These are some key themes for reflection for schools, healthcare professionals, and EPs. Schools need to reflect on their own awareness of health-related needs, particularly in lesser-known conditions. They need to think about early intervention, in particular in the area of self-advocacy for this population. They need to work on making support systems more transparent, and they need to work on how to support students through absences so they don't miss out on learning and social opportunities. For healthcare professionals, they need to align their goals with schools. They need to get involved in health promotion. They need to involve educators in their own action planning. Often they design documents, they work on documents that could be really useful for schools, such as, for example, an epilepsy passport, but they don't really ask what schools need. And so it becomes very medicalized. It's difficult for teachers to work with the document, and it also doesn't include any educational goals, such as equal access to education. Healthcare professionals need to link with schools' medical needs to better align goals. EPs need to think about exploring individual needs in consultations and conversations. They need to think about organizing knowledge exchange opportunities for medical leads in schools within school clusters or geographical units, similarly the way we do it for SENCOs. They need to raise awareness for health-related needs and for this population. They need to promote self-advocacy and independence within this population. And they need to coordinate with schools to plan training that also addresses mental health and learning needs of this population rather than physical needs. In a contact conversation with schools, EPs can ask targeted questions about this population. They can ask questions about the named person within school to coordinate medical policies. They can ask about individual healthcare plans, whether they follow the statutory guidance, whether schools adhere to the statutory guidance, and generally just to raise the profile of this population. Within consultations, EPs can explore learning and SEMH issues separately from physical needs. They can explore any attendance issues, and they can define appropriate support, which is a term used by the statutory guidance, but really needs to be defined for every individual student and school and what appropriate support means for them. On an organizational level, we need to support schools to make the journey from meeting physical needs towards a more holistic approach. We need to focus on knowledge exchange, advocacy, interventions around self-advocacy, and we need to think about harnessing peer power, which can become a very strong protective factor for these students. On a local authority level, we need to explore training opportunities around the impact of physical needs for school staff. We need to continuously assess practice, identify gaps in practice, identify examples of good practice. We need to upskill schools to identify and support mental health needs, and we need to start collecting data on outcomes. So what? EPs are really well placed to raise the profile of this group and to ensure that they remain visible and monitored and that emerging problems are identified early on. EPs can support schools to separate learning and mental health needs from physical needs and make learning and mental health needs the focus of support in order to ensure equal access to education. EPs can upskill schools to identify and support these needs. EPs can advocate for policy coordination. For instance, we work with children and young people from 0 to 25, but health services work with them from 0 to 18. We know that 18 is a crunch point for a lot of young people where they become independent, they move out from home, they start university or a job. And during these times, to then also have to find adult services, it's really difficult. So we need to think about this a little bit and advocate for a change. And communication skills, self-advocacy, and the knowledge of own needs and rights are necessary for all young people and not just for young people with health-related needs in order to become educated voters and decision makers of the future. So we need to reflect on that. Thank you very much for your attention. Bye-bye.